Just take the lead. What is pain? Define pain.
So pain is an unpleasant emotional and sensory experience associated with or resembling that associated with actual or potential tissue damage.
Actual or potential tissue damage. Okay, so what are basic types of pain? Like how can you divide
Fast pain, dull pain,
fast pain versus dull pain? Okay.
Neuropathic pain.
Neuropathic pain versus, you have to tell versus, na? He has said dull pain versus sharp pain. Okay. So neuropathic pain versus nociceptive pain. Okay. What else?
acute pain versus chronic pain.
Very good. Acute pain versus chronic pain. Okay.
Cancer pain.
Cancer pain is part of
Chronic
acute pain. Chronic pain.
Somatic versus sensory.
Somatic versus visceral. Somatic pain versus visceral pain.
visceral.
Okay. So these are different ways by which you can classify pain. Okay. So this is something which you should know. What about how to assess the pain? If someone ask you how to assess the severity of pain, what will you tell?
There are different scales and facial expression.
Okay.
Numeric rating scale is
You just try to organize your answer. Okay. Whenever there is pain, will there be some changes in that patient? There will be tachycardia, there will be hypertension, there may be patient may be irritable. Okay. So always whenever we are rating about pain, so you have to tell about there will be some clinical parameters, as well as there are some scoring system by which we can try to just quantify. Okay. So what are those scores?
Sir, in adults, it's mostly McGill pain questionnaire used.
Try to be very simple. McGinn pain question is not for acute pain.
Right.
Visual analog score.
Yes, visual analog score, numerical rating score. Okay. So these are the basic.
Flat scale.
I'm sorry. We will just try to
Real analog.
Visual analog score.
It's isn't it for children only? Visual analog one.
It can be for anyone. Numerical rating score 1 to 10. Okay.
Yes.
And what is, because I'm not very good at it, because I'm not doing pain practice, so sometimes think we will just try to go through this book actually, because the people around me like the word book, so I just try to find some book for you. Okay. So what are okay, we will come back to the pain assessment. What are deleterious effect of pain? Why pain is important for anesthetics? Why it is being called as the fifth vital sign? Why?
Sympathetic overactivity.
Okay.
Tachycardia.
No, you are not answering the question. Why pain is important? Sympathetic overactivity, tachycardia, what result? Resulting in myocardial. You are telling the right thing, but not in appropriate way. Myocardial oxygen demand supply ratio is disturbed. Okay. Because of this sympathetic activity and tachycardia. What else?
So intraoperatively, it tells us the signs of pain would tell us that the analgesia or anesthesia is not adequate.
Okay. Stress response. So it will be resulting in catabolic state. Okay. So that will be resulting in poor wound healing. We are at the moment discussing what are the effects of pain. Okay. So ultimately, this is the main two things. If someone asks you what are the otherwise you can tell anything. Now the rest of the thing, you can take any system and you can find out a number of things. Just a second. I think because it has come before, so we can just discuss about this thing first. So what you were saying, numerical rating score from 0 to 10. 0 is no pain and 10 is the worst pain. Visual analog score, similar thing. Actually, the purpose is only there's some in our culture. They also ask with the coin. Okay, that how much part of the coin pain is having. It is 1/4 or 2/4, half or 3/4 or 4. So it is also which is being used. So visual analog score, numerical rating score, and verbal rating score. None, mild, moderate, severe. Okay, so you just recall the name, but before answering this, it will be looking like they will be evaluating the patient, and on the basis of clinical features, you will be able to assess the severity of pain. Okay, and then in the children, the face will be telling you a lot. Patient is crying or not crying. This will be for younger patients. This Wong Baker faces. Okay, and then there are certain I have no idea about it. Cries. What is that? Cries. And this one one is cries scale. One is comfort scale. Comfort scale is having 8 parameters. They have just mentioned here. Okay, just a second. And does anyone know about it? Comfort scale, because I need to open the article. I will just show you later on. First of all, just try to assess that if someone asks you this question, how to assess the severity of pain, you will be answering in that way. I have told you that you will be evaluating the clinical features, and then after that there will be some scales or scoring systems. Okay, McGill pain questionnaire, which you were saying, was for chronic pain. Okay, so as I was telling you, examination of the acute pain patient, blood pressure, heart rate, respiratory rate, temperature. Why there will be temperature? What's the relation of temperature?
Because pain is part of the inflammatory process.
Yes.
It is one of the components of 4 cardinal signs of inflammation: tubal tumor, dollar, callus, function like that.
Yes. Okay. So that will, and the pain may be associated with some injury. Okay. Sometimes pain will be associated with some injury. So you can have signs of infection. You can have signs of injury as a cut, hematoma, or in chronic conditions, these will be the conditions: inflammatory conditions, malignancy, ischemic pain. Okay. Limb ischemic pain. If there is some damage to the nerve, there will be pain. Metabolic disorders. Can you give example of metabolic disorder having pain?
Disease.
Just example that which metabolic disorder there will be pain.
Diabetes.
Very good. This will be electrolyte imbalance. Electrolyte imbalance will result in crampy pain in the muscles. Okay. Okay. So in the evaluation, then one will be acute pain and one will be chronic pain. In chronic pain, neuropathic pain. Neuropathic pain is the pain in which there is some involvement of some disordered response of nervous system. So to be very simple. Okay. If it is in the simple way, I will just tell you about a few words about pain pathway. So actually there are 4 steps. I have discussed this a number of times. One is transduction. One is transmission. Third is modulation. And 4th is perception. Okay. Why it is important? Because we have to, as a pain physician or as a pain specialist or as acute pain management, we have to try to cover all these 4 steps. Okay, because transduction will be through the nociceptor. Okay, Then
generation of pain signals.
yes, then it will be new. This one action potential is generated, and it will be transmitted through two pathways: C fibers and A delta fibers. Okay, so the next stop will be spinal cord. Okay, then from spinal cord it will cross to the other side. In the spinal cord, it will go to the other side, and it will travel to the thalamus. So this point is very important, because whole of the concept of gate control theory lies here. Gate control theory. I will just elaborate later further here. That we say from the periphery, signals come. You label it as first order neuron. Okay. And then it comes to the spinal cord, and there is a door. It is receiving inputs from two. One is A delta. That is the one we were talking about. And there is another, which is A beta. Beta is big for beta. Okay. And it is, you can, in simple word, it is bribing. It is bribing the door. Please don't open the door. So this A delta fibers will go back. Like go back means it is not letting the pain to be transmitted from the spinal cord further on to the brain. And the brain, the grandfather will not come to know what is happening. So this is the concept of gate control theory. So which medications or which processes act on gate control? Yes, Zishan?
Hence.
No. Capsicum.
Yes, sir.
And electrical therapies. Electrical therapies. Okay. Electrical therapies like TENS, like acupuncture, like acupressure.
Which one, sir? Last one?
Acupressure. Same like acupuncture. Okay. It is similar to acupuncture. Acupuncture is through electrical stimulus, and acupressure is through pressure. And TENS is transcutaneous electrical nerve stimulation. Okay. It is almost having the same mechanism. The result, if you forget, you just remember that there is a door in the spinal cord, and these things, capsicum, how it does it? It releases substance P.
Yes, sir.
And it is also stimulating A beta fibers. Okay. So it is acting on the same way. When you put capsicum cream, so you feel actually sort of pain-like sensation. Burning pain. Okay. So that will be helping in that way. So similar thing which occurring is spinal cord stimulation, which is being used in chronic pain. Okay.
Sir, isn't spinal cord stimulation among the ones of modulation?
Modulation as well, but actually this is also modulation. What is this gate control? Gate control is modulation.
Sir, gateway theory is for stopping the transmission.
You are right, but it is sort of modulation as well.
Right.
Okay. You are modulating the system in a way that, like I give you example, like if you use this word modulation. So modulation is at number of steps. What about concept of primary hyperalgesia and secondary hyperalgesia? Okay, there is a triple response. Whenever there is injury, there is a triple response for this flare, and actually what happens that inflammatory mediators are released. Okay. And they are inviting more inflammatory mediators. So actually it's a vicious cycle which is occurring. Histamine and bradykinin and this interleukins and everything. Okay. So the one which we are giving NSAIDs, it is not only doing modulation. Okay. It is also blocking the transmission. Not blocking, decreasing the transmission. Okay. Because if there will be less mediators, there will be less transmission. So this is the mechanism of NSAIDs, that they are actually doing, and that is why there is another terminology you can clarify at the moment is preemptive analgesia. What is the concept of preemptive analgesia?
Sir,
Giving analgesia before surgery or before
Before
starting of
the
pain.
before initiation of the pain stimulus. Okay. So one of them is to give what else? What else is given? One is NSAIDs. What else we give in preemptive analgesia?
gabapentin.
Gabapentin. Okay. What is gabapentin?
It's GABA antagonist.
You are absolutely wrong. It has nothing to do with GABA. I don't know why they called it gabapentin. It is anti-epileptic.
Yes, it is antiepileptic.
It is acting on sodium channel, voltage gated sodium channel. Okay. I don't know why its name is gabapentin. I don't know. Okay, but it is not related to GABA, by the way. Okay, it is anti-epileptic. So we give gabapentin and it has opioid.
There was something in its mechanism. I'll search it and I'll tell you I've read about it.
Yes. Please do tell me.
I'll tell you.
Because these days, since last at least 5 years, I'm not studying any book, anything. It is only because of you people that I am hitting my head daily and I am learning something daily. Okay. So anyways, opioid sparing, gabapentin. And other thing which we are giving is paracetamol. Okay. So because actually we just stuck. So we will come back again to this transduction. Transduction is done by nociceptors. Okay. These are usually stretch receptors and they are signaling the pain. And then it is being taken by A delta. Zishan, if I say anything wrong, please don't hesitate to correct me because I am not memorizing or recalling. Sometimes I am bound to do mistake. Okay. So I will be thankful. Anyone in the whosoever is listening, just feel free to comment. Just raise the hand and correct me if I'm saying something which is you are not able to digest. Okay. So transduction and then transmission. We reach up to first order neuron in the spinal cord going to the other side and then through from the spinothalamic tract to the thalamus. Okay. And then from thalamus to third order neuron to somatosensory area. Okay. Somatosensory area. So actually the last step is perception. So more perception is being done in the brain and actually paracetamol is acting on perception. Okay. Opioids, which we use are acting on opioid receptors and they are changing the response to pain, the understanding of the pain. If so, and the medication which we use for chronic pain, okay, usually they are antidepressants and anti-epileptics. What else? These medications. Huh?
Opioids.
Opioids, chronic pain, yes. Actually, there is one more medication which are, anyways, I just slipped out of my mind. So chronic medications actually acting on the brain. Paracetamol acts on COX-3 receptors and it is related to actually temperature control and it is also analgesic by changing the perception, analgesic. It is not, remember one thing, paracetamol is not anti-inflammatory. Paracetamol is not anti-inflammatory. It has separate mechanism of action. It has nothing to do with NSAIDs which we use. So some people are asking, we are giving paracetamol, we should also give diclofenac. So diclofenac is separate, paracetamol is separate. Okay. So this is another thing. And some of the modulation occurs in the spinal cord at the level of thalamus, and give one example of a medication which actually is not analgesic, but it is very effective by acting at thalamus. What is that medication?
Ketamine,
NMDA receptor. Okay. So ketamine has its analgesic. That's why, because thalamus is in between. So that's why there is dissociative anesthesia which occurs. And also ketamine, by the way, another thing, at the ketamine also act on opioid receptors somehow. Okay. Okay. So yes, one more thing is that whenever there is pain, one is the pain, and one are the exaggerating factor which may exaggerate pain, and this is more so in case of acute surgical pain. Okay, for example, if the patient after surgery is having cough, this will increase the the severity of pain. Cough or sneezing, this will badly affect the pain. If the patient has constipation, it will increase the problems related to pain, especially if it is related to, but the problem is that if you are giving more opioids, it is one of the cause for constipation. So you have to optimize the things, and this is one thing. And another thing is that sometimes there are some medications which are being used to blunt the response to pain. Okay, like that is sympatholysis, because we say that whenever there is pain, Dr. Humera said that there is a sympathetic activation. So this is the medication which is the future, dexmedetomidine. Okay, so it is acting on alpha-2 receptors presynaptic, and it is blocking the sympathetic response to pain. Okay.
Also, there is upgradation of the adrenergic receptors during pain, so it also acts on this.
Yes, because like that is the purpose, that is the unwanted effects of pain occurs in that way. So this is another way, and another response to pain is sympathetic system. So one medication which is being used with wonderful effect is lidocaine infusion. Okay, so this is being used even in chronic pains and in acute pain to blunt the sympathetic response. Okay, so just if we just make a so paracetamol, NSAIDs, opioids, okay, and then this gabapentin, dexmedetomidine. Okay. Okay, so what is left? What is the most important thing, which is local anesthetics? So local anesthetics is occurring if you are doing local infiltration. Okay, they are blocking the receptors. If you are giving, I'm sorry,
they will stop transduction.
Okay, and ultimately transmission as well. Transduction and transmission both will be blocked. So this is one thing. What is effect of local anesthetic in epidural and in spinal?
So they act on the reticular activating system.
Okay. The spinal cord?
Basically, this is peripheral.
So basically, they are blocking the sodium. They are blocking the sodium channel. So they are basically blocking the transmission of pain impulses.
Whatever pain is coming, receiving by spinal cord, and then transmitted, will be blocked. Like it is blocking the transmission, all the transmission.
Yes, they act on nerve roots.
Nerve roots. Okay. They acting on nerve roots. Peripheral nerve, I wrote actually peripheral nerve roots, which are originating. Okay. So it is blocking. That's why with epidural, it is becoming a little slow. Please don't use the colors if you can. Whosoever is using this, I don't know how to stop it, by the way. Anyway, so this is another thing that a spinal epidural, how it acts. So it is blocking the nerve roots, and actually it is blocking every sensation all sensation and all the ascending and descending tracts, everything will be blocked. It is sort of spinal cord injury which are creating. Okay. So whenever we are giving epidural and spinal, we are actually creating a programmed spinal cord injury. So whatever is happening, that's why there is fall in blood pressure, there is loss of sensation, there is motor loss, everything is blocked. So this is the concept. Okay, another question, because I cannot memorize the mu kappa receptors. I don't think so. In my life, I will be able to memorize them. If you can memorize, you are great. So, but the basic concept is that what are the effects of epidural opioids? Epidural spinal opioids. They are acting on the opioid receptors, and then
yes, kappa receptors mainly. Kappa receptors are present in spinal cord.
Okay, so you should be knowing, because now Alhamdulillah I don't have to appear in any exam, but you should be knowing what is the effect of individual kappa receptors and mu receptors, which is causing more, which is more related to which sensation. This is coming in the MCQs, but the basic concept is that if someone asks you, is it only opioids when you are giving spinal or epidural? Is it only the places, only these receptors, or are they going somewhere else as well? Yes.
Sir, they mainly act on substantia gelatinosa of the cord.
Yes. Yes. These are opioid receptor. Actually, this is very simple thing, but actually, I you know why I cannot forget it now, because this question was came in 2012. What is the mechanism of action of epidural steroids? Epidural opioids. Epidural opioids. Okay. So I did not write that it will be absorbed. Okay. So it will be acting on the peripheral opioids, not only in spinal or epidural. Okay. It will be acting anywhere, wherever in the body there are, even in the peripheral system, there is enkephalins and endorphins. Okay. Enkephalin and endorphins, which
These
are
naturally occurring opioids,
which are like endogenous opioids. Okay. That's why whenever we are like having pain in Artagal time, what used to happen? Artagal time, only these endorphins were there. Okay. Or they were using, of course, the other things as well. But actually, whenever we are taking exogenous things, so actually this system is blocked. So the opioid receptors are there in peripheral system as well, peripheral tissues as well, where they are acting on through this one. And remember one thing, that opioid, have any one of you received opioid? Okay, no, not pleasuresome for therapeutic. Once I was bitten by scorpion. I just taking a few seconds to tell you this incident, and I received a very, very weakest, one of the weakest of opioid, which is actually not a pure agonist. It was agonist antagonist. So what happened? I was bitten by scorpion, and it was one of the most painful moments of my life. Okay, but I tell you that when I received that opioid, this nalbuphine. Okay, so after that I was having pain, but I was not feeling it. So I was feeling as if I am flying. Okay, I was feeling pain, but it there was pain, but I was not feeling it, and actually I became euphoric. So I tell that day I realized that how beautiful is the life of addicts. They don't care about anything around them. They are laughing and laughing and laughing, and I became addict. Even in one dose I enjoyed what is opioid. Okay, so that is the thing, that opioid, that's why. And I tell you, that's in funny note, I'm just trying to tell you that opioids are not good analgesics. Okay, they are actually not good things. They cause addiction, and they are actually not doing anything much for the tissues. So world is going toward opioid free anesthesia. Okay, and that will be through nerve blocks. Okay, and medications like this dexmedetomidine. Maybe in future we will have dexmedetomidine tablets or things like that, which are away from opioids. Okay. Even as of today, if you are using a combination of lidocaine, ketamine, and with dexmedetomidine, okay, and paracetamol and any NSAID, I can guarantee you that the opioid consumption will be minimal. Okay, if you are using at least for acute pain. Okay, and post-operatively, if you want to avoid opioids, you just give a nerve block. Okay, you can give spinal or epidural. Okay, or you can give a compartment block. Okay, and you can give a peripheral nerve block. So this is the basic theory of pain. I have just tried to simplify it. Okay, and the basic system is that you block the different steps of pain pathway. This techno sport, if Spark, if you can please mute yourself, because your voice is distracting me. Okay. I'm trying to, anyway. So this is one thing which I wanted to tell. So up till now, we have started from our definition, assessment, okay, and then deleterious effect of pain. And then we just try to have a pain pathway, and we just try to learn different pain therapies. So one are medications. We discuss about some of the medications which are acting at different steps of pain pathway: transduction, transmission, modulation, perception. There are some other therapies which you should be knowing just about. There is one is cryoanalgesia. Okay. One is radio frequency ablation, and one is neurolytic blocks. Okay. So, I think I will have to remove this person. I don't know who is he, because I'm disturbed. Okay, Zishan, what is the mechanism? What is the working principle in cryoanalgesia?
Cryoanalgesia, basically the part is frozen.
How?
Wherever there is pain. With either it's liquid nitrogen or it's dry ice. I mean, carbon dioxide. I'm not sure.
If you don't
liquid
have
nitrogen,
yeah, actually there is a liquid nitrogen mechanism is that if a gas under high pressure is suddenly allowed to release, it produces cooling. Okay, and that cooling is that effect is Joule-Thomson effect, and that is being used in cryoanalgesia. Okay, it is not only being used for the sympathetic blocks, they are using it, and also they are using for treatment of warts. They are using it as a therapy as well. Cryotherapy is being done for a number of skin problems, and they are doing it. So basic mechanism, this one. And actually we have a very simple cryoanalgesia. Whenever we hit ourselves, our mother, she brings ice. Okay, so actually that is also a cryoanalgesia. Okay, the pain sensation is blocked, and there is vasoconstriction. The inflammatory mediators are actually decreased, so that's why it results in decrease in pain. Okay,
sir, the pain that is reduced by applying cold ice, isn't it because of the gateway theory?
Gateway theory also, I think it gateway theory will
no, gateway theory works on pressure, not temperature.
I'm not sure about it, but by causing vasoconstriction, it is reducing the inflammation.
Yes, the mechanism is vasoconstriction. Yes,
that's what I can. Maybe it is gateway theory. Maybe I'm not sure about it. Okay. So other theories.
Gateway theory has a relation with the pressure. With the pressure, if we apply pressure, the alpha fibers, they get
pressure, any tactile stimulus,
pressure or rubbing
that will stimulate
but not temperature. Yes,
pressure might not be in it. You're right.
Okay, so another, I am not very good at it. If please help me, Usman. What is radio frequency ablation? This is one we are giving cold and one is we are giving heat. Okay, and actually this is mainly in use in cancer therapy, radio frequency ablation. Okay, so I think
Yes, there is a micro electrode. Yes, there is a micro electrode that we placed on a ganglion or a nerve fiber, and we apply electric current, and
this
that
is
gets
high current,
that
high
micro
frequency
electrode
current,
that gets, yes,
high frequency
yes,
current.
high frequency current.
Okay,
And we should apply, it's just similar to the electrocautery.
yes,
The
and
principle is same.
remember one thing, because they are using it in cancer, these blocks, there will be next block which we will be discussing is a neurolytic block, radio frequency ablation, or this one neurolytic blocks. They usually they have to do a sympathetic block before that. Usually, okay, they see the response of sympathetic block and then they do it usually. Okay, so the radio frequency for the
RF
juniors.
is also being done.
Mhm.
RF is also being done for osteoarthritis of knee.
Yes,
Yes, that is
actually,
called medial rhizotomy, medial nerve root rhizotomy, the medial branch of the spinal nerve that is basically supplying the facet joint. So yes, the medial rhizotomy or the nerve ablation is also used in this
yes,
procedure.
for the words for the juniors. Now we are talking something big plus, but please relax, don't worry. Radio frequency ablation, remember one thing, that there are heat waves which is damaging the nerve. Okay, and when the nerve is damaged, it is not taking the pain pathway, so it is blocked. So that is the concept of radio frequency ablation. So usually it is not used in acute pain, or we are not burning the blocking is damaging the nerves like that. Okay, so this is the concept of radio frequency ablation. Now the next is neurolytic block. Okay, neurolytic block, what is that? Neurolytic block, we use either alcohol or phenol. Okay, so what is the mechanism? That usually it is causing the destruction of the tissues, destruction of cell wall and proteins.
Yes, and precipitation of proteins.
Precipitation of proteins, precipitation. Okay, so cell wall is of lipid and protein, so it is damaging it. So the nerves are damaged. So it will be not be 100% permanent, but it will be for some time. What is the problem with alcohol? It is painful, and it is hypobaric. So whenever we are giving alcohol, the side affected side will be on the top. Am I right, Usman?
Yes, sir. It's hypobaric.
Because it is hypobaric,
yes.
it will go up. So whenever we are injecting it, the side or affected side should be on the up. Okay, and the other one is phenol. Okay, when we are using phenol, it is hyperbaric, and it is or isobaric, and it is painless. So for alcohol, we need to add lidocaine or bupivacaine, whatever we want to add. Okay, so this is something words about it. You can read in detail about it. I will just go back to what I was trying to say. This is also coming in MCQs. Hyperesthesia, hypoesthesia, hyperalgesia, hypoalgesia, increased pain or increased sensations or decreased sensation, hyper or hypoesthesia. Okay, hyperalgesia and hypoalgesia, increased pain or decreased pain. Okay, so hyperalgesia, I will just give you few words about hyperalgesia. It is usually caused by opioids sometimes. Okay, and itself, like I will change my statement. Itself, opioids may be a culprit for hyperalgesia, and the drug for that is, what is the drug which can cause hyperalgesia? Yes, Ishan?
I don't remember.
Remifentanil. Okay, remifentanil will suddenly, because its effect will finish very quickly, so it will actually cause severe pain. As soon as it is metabolized, it will cause severe pain. So it is called as opioid-induced hyperalgesia. Okay, so that's why when remifentanil infusion is being used, it has to be supplemented by other medications, fentanyl and morphine before stopping it. Okay. So paresthesia, dysesthesia, allodynia. Allodynia is the pain where there is no sensation. Just correct me if I'm wrong. Okay.
Sir, allodynia is
No. I'm
on
sorry. That is
non-painful
anesthesia.
stimulus.
Yes, anesthesia dolorosa, which I have told. The pain in the area where there is no sensation. That is anesthesia dolorosa. It's not written here, I think. Allodynia is if you are touching it and the other person is saying you are causing me pain. Okay.
Yes, neuropathic like.
Yes. So in neuropathy, this hyposthesia, hyperesthesia, hyperalgesia, allodynia, paresthesia. Paresthesia, you know why it is when we are doing any nerve block or even spinal and it is touching it, the sensation which is caused is paresthesia.
Yes, abnormal sensation.
Abnormal sensation. And I failed to understand what is difference between paresthesia and dysesthesia. These used to
Sir, dysesthesia is uncomfortable sensations, but
Unpleasant.
paresthesias are abnormal sensations. The difference is just comfort or unpleasantness, nothing else.
Anyways, I'm like it is. They are very close together.
Yes.
They are very close together. Anyways, psychological aspects of acute pain at examination. There is like effect on psychological. There will be problem with the sleep. Okay. So there are so many problems which will be associated with the with pain. Okay. So pain, and then yes, that's what I was telling you before. Cardiovascular system problems, respiratory problems, GIT. Okay, genitourinary, metabolic, like catabolism, as I told you that there will be catabolism. Okay, so catabolism is not good for wound healing and everything, and the patient will go in a negative cycle, negative protein balance. There will be catabolism. Okay, so this is we have discussed, and now we will just try to go into some of the conditions. What is chronic post-surgical pain? Yes. Have you read about it? Anyone wants to tell it? What is chronic post-surgical pain? For the people from Pakistan, we have a special association with this word because this is a constant source of pain for us. Am I right? Till the time we don't pass our exam, this is CPSP. And it is also our College of Physicians and Surgeons, Pakistan.
Chronic surgical pain, post-surgical pain, basically this is a pain which develops after a surgical procedure.
Okay.
It occurs. It is persisting pain beyond 2 to 3 months after the surgical procedure, and
it is not correlating with the actual tissue damage.
The actual tissue damage.
Okay. So if it is continuing more than I think 3 months.
So chronic
post-surgical. And what we will just go to it. But I just saw this, and so which surgical procedure are again there will be surgical patient and anesthetic factor. But if you just try to say, because this you should remember it and you will tell it that you should have a very good pain control, or you can use this statement usually in any patient that acute pain management is very important, because if you don't have a good acute pain control, the patient will have chance to go in chronic pain, chronic post-surgical pain. Okay, so the procedures which are culprit are like
amputation.
Amputation
is 35 to 80%.
Yeah, you will be surprised that cesarean section is one of the procedure which is associated with post-surgical pain, chronic post-surgical pain. Mastectomy, hernia, it looks very simple operation, but you see hernia is a very high incident. Thoracotomy pain is one of the most severe. It is also related to chronic pain. Okay, so these are some of the procedures which are related to chronic post-surgical pain. You said amputation. Actually, amputation has more of
phantom limb. Yes, phantom limb is more common.
Yes. Okay. Okay. So
phantom limb also, but CPSP is also the most common in amputation.
Yes. Okay. So we will just, okay. So another question, because I'm trying to cover as many aspects as possible, This question is possible to you people. It's a very simple question, question to answer, but if you don't have any idea, you will not be able to answer. What is acute pain service? Okay, it is anywhere in the post-operative period or in the emergency, or any patient who have some acute illness and is causing pain. There is a dedicated pain team with nurse, with pharmacist, with anesthetist, or dedicated pain specialist, okay, who is providing increase, decrease, management, or anything to control the pain. They will be evaluating according to the scenario. They will be evaluating the patient, and then anything they can add or increase or decrease. Okay, so that is the concept of acute pain service. Nothing difficult. There is no science. The same answer which I have told you, this is the answer. And similar pain team is there for chronic pain service. Okay, what is difference between acute pain service and chronic pain service?
So in the service, I don't think there's any difference. It's not in the emergency. It's only in the OPD, in the pain clinics.
And usually it will be a multidisciplinary team, usually, because it will have some palliative therapy,
Psychologist and physiotherapist and all
physiotherapist, psychiatrist, psychologist, surgeon. Maybe they are planning to do some palliative procedures. Okay, so actually once this question was being asked in our exam, what do you mean by palliative care? Okay, so palliative care question is being asked at what WHO says about palliative care. It was question asked to me, but at that time I was not able to answer. But actually there is involvement of
palliative care
dependence. Yes, sorry.
Palliative care is basically the care provided to patients who are terminal. Where there is no definite cure for the disease, and it is going to lead to their death. So we have to make their life comfortable by any means possible.
Like palliative surgery means that we are not treating basically the actual disease. We are just soothing the symptoms of pain.
Like like these neurolytic blocks,
include surgery, it can include pain blocks.
Yes, it will be like, for example, if there is a cancer, abdominal cancer patient. So if you are opening the stoma, this is palliative care. Okay, if you are
reducing the tumor mass, reducing the debulking of the tumor, so that they might reduce the pressure effects on the surrounding organs.
Yes, we are giving any celiac plexus block or any sympathetic block with neurolysis or radiofrequency ablation. This is part of palliative care, and this is also part of chronic pain management. Okay, there are one thing which is not common in our part of the world, but it is very common in Saudi Arabia. This is sickle cell disease. These patients are crazy. Because I have not done much of chronic pain, but these patients, you are very difficult to treat, because
so
they
we are using
PCA
pumps for them.
Yes, PCA. Yes, I forgot
PCA
to tell.
morphine. I am working in Saudi Arabia, so we are using for the sickler PCA, patient control anesthesia, morphine or fentanyl.
Yes.
And we have more other options also. But we are regularly dealing with 3 or 4 patients like sickle cell disease or TRID. If they are in crisis, they really need. Sometimes the demands and goods are in hundreds.
Yes. So that's what I was telling you, that now you can understand that it is very difficult to treat. Okay. Sometimes the patients are literally crying. They are fighting with the staff. They are fighting with the doctors. So it is really difficult to treat sometimes, because because there are so many things which I want to discuss. Like there are some oral opioid medications with
Tylenol, codeine with it, plus paracetamol, hydromorphone, fentanyl patches,
and tramadol, fentanyl patches, fentanyl,
dermal patches.
Okay, so this is actually very difficult to treat. So chronic pain, they can ask you what do you mean by palliative care? So you don't have to worry, and you have to tell these things. What is acute pain service? As I told you, that it is a service provided to acute post-surgical patients or patient with any painful crisis coming in the emergency, and emergency physician needs advice from the pain specialist. So you are giving the same thing. The concept of just one more thing I need to tell is, what is WHO pain ladder? Yes, anyone?
Yes, step ladder. Yes, step ladder.
Step ladder.
We
There is
start,
one ladder for chronic pain and one ladder for acute pain. What is the difference in it? Maximum to minimum. And it is minimum to maximum. Okay. This is the basic theory. And the acute pain management, I say this example, that if you have a fight with someone, if you slap slowly, that person will slap you very hard. So if you want that person don't slap you back, you first punch should be very hard. So this is the concept of acute pain management. Okay. You start with the maximum and you gradually come down. Okay. So this is a step ladder, like we start with in chronic pain, we start with paracetamol. Okay. And then we add weak opioid. Okay. And then we add strong opioids. So this is the theory here. Okay. And opposite it in the acute pain. Okay. So this is one thing, quality. Anatomy of pain network, receptor, primary efferent. We have discussed actually these things, secondary order neuron, nociceptor and primary efferent neuron, dorsal horn. We have discussed about it. Actually, I have to tell some important aspect, because usually if they ask what is the pain pathway, so if you tell the basic theory, you will pass the exam. So basic, because pain is a subspecialty, so they are not expecting you to tell too much details. But I have found this book as one of the best source to revise, to prepare pain topic. Okay. So, okay. Actually, there are some important pain topics I will just try to tell, because this was in eve of, I have discussed some of the topics separately. What is post-herpetic neuralgia? What is trigeminal neuralgia? Okay. And what is NICE guideline for neuropathic pain? Okay, anyone please.
Post-herpetic neuralgia is basically it is a chronic pain which will occur after herpes zoster infection.
It's a neuropathic pain.
Neuropathic
pain. Usually it occurs after
herpes zoster infection.
Acute herpes zoster shingles. Okay. So what is the theory of it? Varicella zoster virus. Okay, residing in dorsal root ganglion. Okay, so it is causing mucopapillary rash. I don't know the exact. You just reconfirm it. Is it mucopapillary? Is it skin?
Yes, it is mucopapillary rash.
Sorry, muco.
Isn't it a vesicular rash?
Vesicular.
Because there are vesicles.
Okay. So I am actually very expert in it because I suffered from it. I was in medical college. I have suffered from shingles. It was a terrible pain. Anyways.
Have you taken acyclovir?
Yes, acyclovir, 100 tablets daily. Can you believe this? 20 tablets daily.
Yes, sir,
20 tablets daily. Alhamdulillah, I was saved from post-herpetic neuralgia, but I can tell you that it was a terrible pain. Oh, I can recall it. So I have a special association with some of the diseases.
And sir, we don't have any lidocaine patches here, capsaicin we don't have in Pakistan. So
yes, lidocaine
patches.
Lidocaine patches, this capsicum patches are available. I use myself actually. I am having chronic pain, so I am using capsicum patches. Capsicum patches is available in Pakistan as well as in Saudi Arabia anyways. So this one, and what is the another treatment is acyclovir. Okay, if it is because there is burning pain. Okay, so in burning pain, if it is giving acyclovir at that time, the response will be good. Otherwise, there will be severe pain. And in any neuropathic pain, you will tell about tricyclic antidepressants, anti-epileptics. Okay.
Anti-arrhythmic.
So the treatment of choice in trigeminal neuralgia in post-herpetic is gabapentin.
Gabapentin.
First line is gabapentin, and then the TCA is
first. What is carbamazepine? Is first line in trigeminal neuralgia.
Trigeminal neuralgia.
What about diabetic neuropathy?
Duloxetine.
Duloxetine.
Yes,
Duloxetine. If juniors, if they are listening and are worried, I will show you the article for it, and you can. I will tell you in the later half. I will just try to tell the article. It is there in the pain. So there is an article on neuropathic pain. You will find nice guidelines. So the medications are the same only in trigeminal neuralgia. It is carbamazepine, as he's telling. In this post-herpetic neuralgia, it is gabapentin. Okay. In diabetic neuropathy pain, it is duloxetine. Okay, this is SNRI. There is one as SSRI.
Selective throttling reuptake inhibitors.
Yes, the SSNRI. SSNRI. Okay. So
SRI and SNRI.
SNRI,
right?
yes, I think, yes. Okay. So duloxetine is SNRI. Selective serotonin reuptake inhibitors. Actually, you know, these all antidepressants, what they are doing, actually they are increasing the catecholamines by somehow. Okay. Either it is serotonin, either it is norepinephrine, either dopamine. Okay. So what you say, chemical locha. Okay. So they are dealing the chemical problems. Okay. So actually, if you forget, you will say that the treatment of chronic pain, all post-herpetic neuralgia, I've told you trigeminal neuralgia is the involvement of any of the three roots divisions of ophthalmic or maxillary or mandibular division of trigeminal nerve. Okay. And it is severe, they will write lancinating pain. I still, this dramatic words of Morgan Manus. Lancinating pain, am I right?
Lacinating, burning.
Lacinating, severe. Okay.
Burning, needle-like pricking.
Okay. And in all these pain syndromes, if you fail, then you will be going to surgical treatment or nerve blocks. So they are giving this sympathetic blocks for it. And cordotomy, or I don't remember the procedure name. So if you forget, if they asked you, for the people now recently who are going for this our MCPS exam, if they ask you what is trigeminal neuralgia, just say that it is because of any etiology. The etiology may be anything. It may be injury, it may be infection, it may be any idiopathic, and as a part of diabetic neuropathy. Okay. So it can occur, and it will be that you will be evaluating. There will be some signs of neuropathic pain, and then you will be starting with paracetamol, and then you will be adding. And if one thing is not acting, you will go to second therapy, and then you will have a combination. Okay. And then if it is failing, you will go towards some sympathetic blocks. This is the answer for any, if it is post-herpetic neuralgia, trigeminal neuralgia, the answer is almost the same. Okay. So one is,
I think in all chronic pains, psychotherapy and the stents, these are included in all the.
All are included.
Yes, I think we haven't discussed about the neuromodulation. We should also touch on this. Like like the Zishan has done TENS therapy, spinal cord stimulation, deep brain stimulation,
Yes,
deep
it
brain
is.
nucleus.
Yes, it is also there. Actually, if you can tell, please, Usman, go ahead. Spinal cord stimulation
Sir,
is, yes.
yes, basically we are in spinal cord stimulation. Two mechanisms are occurring. One is the release of endorphins, the naturally acting or endogenous opioids that are released, and second is they basically increase the descending pathway, descending inhibitory pathway, which are basically inhibiting the pain signals.
Okay.
And in TENS, we all know the very famous gate theory, that we are basically stimulating the nerve and stimulating the area, and it will call the activation of the A fibers, and that decrease the pain signal inhibition. It causes inhibition of the C fibers.
Hmm. Okay,
So
Zishan,
that
I
nice
think.
guideline is in the
Yes,
other article, the
in the other
BJ
article.
article, up to date one.
I think I had,
Nice guideline is not in this one.
not in this one. I had noted down in this in my hard copy, so I'm recalling the same thing. Yes. Anyways, I am now. My energy is finished. So some of the important topics are left. I will try to cover tomorrow, inshallah. CRPS, phantom limb pain. Okay. And another question which can ask you, that opioid dependent patient or addict for a surgery. Okay. So thank you very much. I hope you people learn something, and all of you are welcome to ask anything, anytime, to me directly or indirectly through WhatsApp, or you all are welcome. Okay. The juniors, I can see, I think Zunera, you are from Romania, am I right?
Yes.
Okay, so today I had a big lecture to all of the juniors, and some of them have joined. So thanks for joining. Okay.
Please also mention the name of the book.
It's
Oxford Handbook.
It's Oxford Handbook of Pain. This link, if you spend that much time which you spend in one visit to a mall, shopping mall, I request, if that much time you spend on this link, you will learn everything. Just you just browse through it. If you go to the books, you will find only 5-6 folders, and then you will find books related to you. These are having all the actually so-called textbooks. Oxford is also there. In MCQs books, you will find MCQs related to basic sciences, clinical sciences, some pools. Okay, this is for the people who are in Saudi Arabia for prometric in Saudi Arabia or UAE. I had to put it in the same folder. This is very good books about regional anesthesia. I have told multiple times this one. You don't be afraid of so many books. You can only do what you want to do and what you can do. Okay. If you open this book and at least read 1 or 2 chapters related to the basic concept of pain, you will learn a lot. Okay. So actually it is just like window shopping. Okay. You don't need to buy everything, but you can just have a window shopping here, and you will find the thing which are related to you. SAQs books. The people in Pakistan who are now only addict to MCQs, they never look at these books. Oh, this is not our pattern. Believe me, these books are such nice books. Just yesterday I bought this book and I have put it in the folder here. Okay. So this is excellent books. And you don't need to read each and every line, for God's sake. You just have to take the question. Okay. Like, for example, if you open this, just trying to open this book, for example, and you just have a look what are in these questions. Okay. See, you will just find questions and you will just try to find the answer. If you don't know, you can see the text, what is written here. Okay. So this is excellent practice for you. Okay. Define a ICU acquired weakness. List 3 classes of ICU acquired weakness. List 6 risk factors for development of ICU acquired weakness. List 4 clinical features of ICU acquired weakness. Your whole of the topic will be covered. believe me. But unfortunately, you are not in habit of studying like that, okay? Because you are in habit of worshipping Manhus Morgan. So it's not easy for you to swallow. OSCE books, I will highly suggest the residents to have a look on it. The junior residents, okay? You will find OSCE books and you will find small tasks, simple, very simple. They will be talking about supraglottic airway devices. They will be talking about any minor complication occurring. So you will find a number of things you can do one by one, okay? So this is for OSCE books, and there are samples for ECG, ABGs. Okay, you see anything, you will find X-ray. If you want to learn about X-ray, you will find a number of presentations for X-ray. Okay, unfortunately, you don't have time. You are all busy people. Only in the world.
Sir, actually, there is, sorry
Yes.
for interruption.
Yes.
There is one book that is Harman Shambi that you have also uploaded in your drive. It's the recommended book. And I found it very good because it actually covers each and everything that you need to,
what is this Harman Shambi? Because maybe I know it by other name. Is it SAQ book or what?
It's the MCQ book, but it describes the explanation in a very good way. It's the pain therapy in regional anesthesia. You have it in your folder.
Yes. It is a master pass. Okay.
Yeah, exactly. This one.
Actually, the people know few of my friends now. Jamil is also passed, so he's not here. This is my darling book. I have read this book a number of times.
Which one, sir?
This master pass.
This master pass, and most of the questions that came in the last time in IDIAC exam were covering, like, if you cover this book, it was like covering your most of the topics.
Actually, some books are written in the way that they are in your native language. Okay, when you are reading, maybe you are thinking that it is in Tamil language or in Punjabi language. Okay, so this is one of the book which is very, very easy to learn. This is excellent book. Okay, so this is very good book. And another book which I have learned a lot from that book, I will just show you, is again, I will say this is my darling book. These two books are excellent. If you want to clarify your concept and you want to have a very good review, these two books are excellent. And all of these books are very good. But these two books are, people are in love with the podcast. Podcast is very good, but podcast is very old. Remember, these books are much newer than this one. Okay, this is another folder which I don't think so any one of you have opened.
So there is a book I'm reading, that Master Pass Final FRCA. Do you recommend this book?
Yes,
actually, all the master pass are actually very good books, because a lot of questions that, yeah.
Okay, so actually this is from some of the resident. I found it here and I uploaded it here, and actually it has pearls of all the topics. And just a second. It's not opening here. I don't know what is the problem. Actually, all the time I open, maybe it needs some software, but it's a collection. Okay, it's there in the this folder.
Yeah, it's 150 topics, I think.
No, it's not 150 topics. It is if you just try to open it, it is excellent source. It is some sort of notes. Okay, and then similarly, if you want have some ICU exam, again, these are some of the collection of ICU books, because in ICU, I will suggest, if someone wants to have a review, this is very old, but this is very good. This is almost 10 years back. This was published. If you delete the recent guidelines for recent topics, like remove cardiac arrest, remove some special guidelines for VAP or ARDS, this is excellent source. Okay, this is excellent source. So this is how you can, the basic sciences. Okay, if you want to clear your concepts, read this book. You will find all your topics. You will be and some topics, if they are not covered here, you will find it in a master pass. This is for physiology. This is for pharmacology. And these are some other books. This is primary FRC in a box. It's a quick revision of the things. So don't try to read basic sciences from anywhere else. Okay. And this folder is for physics equipment. So I will suggest you these two books, number 1 and number 2. Okay. Majority times I have just tried to number them. This book is excellent for any equipment in anesthesia, any monitoring in anesthesia. This is for basic sciences concepts of physiology, pharmacology, physics. It is excellent. These two books I will highly suggest you. And rest actually is just for finding any specific topic. If you want if you are not cleared, you can go in detail. You will find one file here. This is by one of our professor back in Pakistan. Okay. And she has just tried to correlate the, she's a very senior professor, and she has just tried to cover some of the clinical application of gas laws. Okay. Physical principles of gas laws. So it is also very helpful if you want to clear your concepts of basic sciences. Remember one thing, basic sciences you should be reading correlating with the clinical sciences. Okay. If you are trying to have basic sciences separately, that's what the order is being given to the juniors. Please finish first 15 chapters of Morgan. And that is the most crap thing which can happen to any resident, unfortunately. Because if you are trying to read it separately, you will never understand and you will never be able to swallow it. Okay. But if you are clinically correlating it and going step by step, it will be very easy for you. Okay. So I have taken a lot of time. Now I am leaving. Thank you very much. And any question, any one of you is welcome. All of you, all the recordings which are there are available on the YouTube. You can all subscribe to the channel and you can find everything. I have no political, financial, any sort of conflict. Even if I earn something from YouTube, I will try to do something good for the residents. Like 2 years, 3 years ago, I just had some contribution from some of my friends, and I bought a ultrasound machine for the residents. It's still there with the hospital where I was working. Okay. So I will tell you that sometimes you have to bring out your time out of nowhere to help others. And remember, if we do it, then the world will become a peaceful place. Exam studies is the worst thing, but the problem is that if you don't learn, you will be in trouble. And I say this word, the last word, and then I'm switching off, that would you like your family members to be anesthetized by people who are only passing the exam and they don't know anything? They are having some notes, some shortcuts, some things like that, and they are passing and they are giving anesthesia to your mother or your father. Would you like it for yourself? So don't be like that. Okay. Thank you very much.